Erica mentioned, my name is Lisa Hill. I'm the pediatric trauma coordinator at Ascension St. John Hospital in Detroit, Michigan. And today I'm just going to kind of review a basic pediatric assessment head to toe. We're going to go over some of the common calls that we run on, and then how we treat those patients as well, and including the documentations. So just a little bit of numbers, as I like to call it, is that there was an estimated 30 million children that visited the emergency room in 2017. The problem with that is that even though there's a lot of kids, you're like, holy, there's a lot of kids, that's 30 million. When you look at the number of pediatric patients that an individual EMS provider runs on in a given year, it's very small. When I was working the road as a paramedic, there was very few pediatric patients that I would run on. And I remember every single serious pediatric patient that I ever ran on. All those deaths, I can still visually remember where I was, what the cause was, etc. So even though there are a lot of kids that are coming to the hospital with sickness and injuries, on the individual level, we really don't see a lot, unfortunately. Traumatic injury is still the #1 cause of death in children aged 1 to 19 years old, and most of those are traumatic brain injuries. There's over 2,000 firearm deaths and over 3,000 deaths from motor vehicle collisions. And in 2017, there was over 1,700 deaths from child maltreatment. So kind of what I touched on just a second ago, although the individual EMS provider may not run on a lot of pediatric calls, it's imperative to be prepared at all times. Every morning when you come into your shift, you need to be mentally preparing that you could run a call at any point on a pediatric patient, and ask yourself, am I ready? Do I feel comfortable running that call? So kind of starting at the beginning, our scene safety, mechanism of injury, additional resources, kind of going back old school EMS education. Every day, check out your truck. Do you have a separate pediatric bag? Do you check that bag out every day? When I was on the road, I would check that bag out myself. It was just one of those things that I wanted to make sure everything was there. If I was with my partner, I would fight and say, hey, I'm going to check the piece bag out. Make sure you have your equipment in all the sizes. Make sure you have your length-based resuscitation tape, whether it's in that bag or somewhere else, know where it is. When you're going en route to the call, whoever's not driving, make sure, you can look up what are the norms. If you're running on a 20-month-old kid, look it up on the way. Look up, find the normals, ask your partner if you're the one driving, hey, can you pull up the vital signs? Can you pull up, the weight, etc., what the normals would be for this child. So you're not doing it once you get on scene, especially if you need to do medications or defibrillate, etc. Have you ready to go. Standard precautions, of course, your safety vests, gowns, gloves, eye protection. Unfortunately, with COVID, we've gotten all too comfortable with this. It's not as something that has to be driven into our heads anymore as it once was. Scene hazards. Remember, this can be traffic, and that's something we always know. Down electrical wires, hazardous materials, violence, but then when you're going into the homes, loose animals, and even family, bystanders can be a hazard, a scene hazard. And the crowds. Pediatric calls are very stressful, and everybody just wants you to grab those kids and go. They may not understand that you need to be there and you need to be doing what you're doing to stabilize that child, and it may become a dangerous situation for you. Just keep in mind, it's stressful for everyone, the providers, the parents, the bystanders, etc. And the mechanism of injury. Obviously our patient care is #1, but really being able to give a good description of the mechanism of injury does really help with the care of that patient once they are at the facility. Whether or not the patient was in a car seat, whether they were restrained, where they were in the vehicle. We'll talk about that a little bit more too when we get into the documentation. And so I've seen it myself when I'm reviewing calls. I read the run reports, I read the EAD reports, and you will see that story change. The parents will lie. They don't want anyone to know that their child wasn't restrained. And so EMS, if they document that, that really helps us out, because then we'll start to read the ED notes and we'll see that the parents actually said, oh no, they were restrained. In reality, they weren't. So assessment, the pediatric assessment triangle. This pediatric assessment triangle is something we do on every single patient we run on. It's our across the room observation. What does our patient look like when we're walking in? You walk in and you automatically always look and go, okay, this patient is sick, gonna have to work, right? Or why did I get called? Not really sick. Or, oh my gosh, this is not gonna go well, or this guy's really sick. So we do that with every adult patient. But with the pediatric patients, they're so stressful. I don't care if you're a paramedic, an EMT, a nurse, a doctor, those calls are stressful. So this pediatric assessment triangle really took that first look across the room observation and broke it down into 3 sides: the appearance of your patient, the work of breathing, and the circulation. And if one of those things are off and not normal, then that patient is sick. If 2 or more is off, then they're really sick. And so that's just a way to go, okay, you're walking in and to kind of just remind yourself, appearance, what is my kid looking like? Okay, a 2-month-old may not even care that you're there, right? That's normal for them. But a 2-year-old, 3-year-old that's not paying attention to you, and you've got a group of firefighters in full turnout gear and paramedics standing in their room at 2 in the morning, and they don't care that you're there, that's a huge red flag, because their appearance is off. You also can use the mnemonic tickles, right? Their tone, their interactiveness, consolability, their look, their gaze, and their speech and their cry. The work of breathing. You can see in this picture, this kid is tripoding. He's positioning himself to get the most amount of air into his lungs. Does the child have retractions? Do they have accessory muscle use? Or they have nasal flaring, head bobbing, any type of work of breathing. And then circulation, okay, pallor. Are they pale? Are they modeling? Are they cyanotic? Are they blue? Looking at each one of those things help you classify and give you that, okay, I can take a deep breath. It's going to be okay. Kid needs some help, but we've got a little bit of time to work here. Or really sick and we really got to get a move on and get our treatment started on our patient. So once we've done that, we move on to our A's, our airway and alertness, using our cervical spine restriction as needed. So ABPU, okay, are they alert, verbal, painful, or are they unresponsive? Make sure we're stopping any major bleeding, of course. As a trauma nurse, I have to say that. Assess the airway for any obstruction. Okay? Remember that tongue is a major cause of obstruction in those kids. And just opening the airway, with a jaw thrust or head tilt, chin lift might really relieve that, that tongue. Okay? Decide if you need an NPA or an OPA or an endotracheal tube. If you've got here snoring, that means their airway is obstructed. Anytime you're snoring, you're probably going to be able to get an NPA or an OPA in that child. And if you can get an NPA or an OPA in that child, then they need to be bagged. If they need to be bagged, you got to know they're going to need an endotracheal tube at some point. So listen to the parents as well. They will tell you if the baby doesn't seem to be breathing properly. And they're with that child all the time. So if they're saying that it doesn't seem right, even though you think it's okay, listen to them. They know what is normal for their kids. If you do end up needing to intubate your child, remember that cuff tubes are now okay. They've been redesigned so that they're not putting as much pressure on the surrounding structures. And we want to secure at the teeth of the gums. And we usually need to secure it 3 times the diameter of the tube. So if you're using a 3.0 tube, you know that tube probably needs to go down to about 9. And remember your length-based resuscitation tape, whatever you are using as your, in Michigan, we have my medic cards that give us all the medications and the sizes of equipment that we need. So if whatever size tube you have determined that you need, or the diameter of the patient's pinky, 3 times the size of that tube is how far down that tube should go. Now, it doesn't mean you shouldn't not reassess the course and assess for lung sounds, but at least it gives you a guideline as how far to put that tube down. And make sure you're suctioning as well, something that's sometimes overlooked. Breathing, we want to look for increased work of breathing again, even though we kind of looked at that during our first look at our kid across the room, but we want to look for increased work of breathing, okay? The rate of that breathing. They will fatigue and decompensate fast. So they'll breathe fast for a while. They'll try and keep things going, but they can only go for so long. They're still kids. They're still going to tire out. Do they have nasal flaring or head bobbing? Okay, that nasal flaring helps to increase the size of their airway. It increases the airway diameter. Head bobbing is caused by the use of the neck muscles to assist in breathing. Okay, the child lifts the chin and extends the neck during inspiration and allows the chin to fall forward during expiration. They also have small tidal volumes. So with weak chest and intercostal muscles, they're not as developed as an adult patient is. So they can't increase the volume as much as they can increase the rate. And their ribs are more horizontal than an adult. They also have a flat shaped diaphragm. So the adult patients, they're kind of dome shaped. With the pediatric patients, they're flatter. Okay? So sometimes if they have gastric distension, which can happen in a lot of younger babies, infants, that gastric distension can push up on the diaphragm, and then it can also impede the respirations of the child. So young children will use the abdominal muscles for breathing. If they have abdominal pain or injuries, they may not be able to use that, or they'll stop using their abdominal muscles like they normally would. So that causes decreased tidal volume, leads to shallow respirations or grunting. And listen for breath sounds. They have very thin chest walls, and so it can cause transmission of the breath sounds. So it's important to not only listen to your normal lung sounds, your anterior lung sounds, but also I always try to listen underneath in the axillary areas on each side as well, just to make sure you're not hearing one side on the other side, spreading out those sounds a little bit more. So listen on both sides. And kind of remember that blow-by oxygen is really not effective. So if you think that kid needs oxygen, you need to put a nasal cannula on them. You need to put high flow O2 on them. Blow-by just doesn't work as well as we thought it did or hoped it did. Circulation, moving on to C. We need to look at our central or compare our central and our peripheral pulses. Is one stronger than the other? Are they the same rate? Our cap refill, we have learned that cap refill is usually a reliable indicator of circulation in children. How long is that capillary refill? Their skin color, just as we looked at earlier, are they pale, are they cyanotic? Do they have cyanotic, acrocyanosis where their arms and legs are blue, cyanotic, the trunk is still pink. Kids can compensate, then they increase their cardiac output. Okay? How much the blood is pumping out of their heart in a minute, they increase that by increasing their heart rate. So when you see tachycardia, you really have to think about, okay, are they trying to compensate? So increased respirations, increased heart rate, that shows you that those kids are compensating for something. And it's our job to kind of figure out what's going on and try and help them alleviate that compensation. Going back to the cap refill, remember, you don't have to squeeze the itty bitty little tiny fingernails of an infant. You can press on the palms, you can press on the soles of their feet, even their forehead to check capillary refill. Even though we're taught to check the fingernails, fingernail beds, you can check other locations for cap refill. And that sometimes works a lot easier. And you then use the nail bed for your older kids. Vascular access as needed, and a couple IV tries. If you can't get it, go for that IO if you need to. Okay? And remember, if the kid's been vomiting or had diarrhea or even a fever, that can all lead to dehydration. So it's important to think, okay, they're tachycardic, they're pale, but they've also been vomiting for 3 days. Are they dehydrated? And maybe they need a fluid bolus. Okay? And so if that's the case, how much are we going to give them? What are we going to give this kid? Okay? So 20 cc's per kilogram of isotonic crystalloids over 5 to 10 minutes is appropriate for pediatric patients. If they're a neonate or even kids in cardiogenic shock to try and prevent pulmonary edema, it would be 10 cc's per kilogram. Okay. So after each bolus, you want to assess for breath sounds, okay, making sure that they're not developing pulmonary edema. Okay, you're going to check the pulses again. You're going to check cap refill. Okay, so if you mess with somebody, you need to reassess them. Okay. And this is just showing, this picture just shows a way to pull up those fluid boluses. And it's one of those things to check in your rigs. Do you have a huge syringes, right? Do you have a 60 cc syringe? Because it makes it a lot easier to use, and a 3-way stopcock. Okay, so some agencies, some states, it's required equipment. Other states it may not be, but by pulling up the fluid from a bag of normal saline, This is, you can pull that bolus up and then you can slowly push it instead of trying to dial, and watch. It's very hard to do that from an IV bag. So this is just a way to do a controlled fluid bolus, pulling it up from the bag, using the stopcock to turn it off the bag, and then pushing it to your patient. And you can repeat this 2 to 3 times. You just have to remember to reassess your patient in between each time that you're giving this fluid bolus. For TXA, for trauma patients, there is TXA that we can give our patients since we don't carry blood in the ambulances. In Michigan, they have to be 14 years or older to give TXA. And honestly, the research I did, looking at the research, I should say, not my own research, but has shown there really isn't a lot of good data out there to support the use of TXA in pediatric patients. So usually you're looking at older children, 14, 15 years old, before you even consider TXA for those patients. Another important thing to remember, though, between pediatric and adult patients is that if their heart rate starts to drop, goes below 60, and they show signs of poor perfusion, once you've established an adequate airway and oxygenation, it's time to start chest compressions. Difference between the adult and the pediatric patients under 60, we need to start the compressions. Moving on to D, which stands for disability. Some people like to call it De Niro, like Robert De Niro, haha, funny joke. Anyway, so assessing the neurological status, right? So any alterations in mental status should be considered the result of cerebral hypoxia until proven otherwise. This is the easiest thing to fix, right? If they've got cerebral hypoxia, if we can give them some oxygen, this would be the easiest thing to fix for our kid. So if this is the case, you're going to start to see restlessness, anxiety, fussiness, crying, irritability, or combativeness in our kids. So what consists of a good neurological assessment of our pediatric patients? The first thing is getting the pediatric Glasgow Coma Scale, your GCS on your kid. So this is a modified Glasgow Coma Scale for infants and children.
Lisa?
Yes.
I'm sorry to interrupt you. Is there something showing beyond the title of Pediatric Glasgow Coma Scale on your slide right now?
Yeah, there is.
Okay. Thank you. I think one of the other ones wasn't showing as well. So just we'll let you know if it doesn't pop up. So
okay. That's really weird.
Yep.
I've never
had that photos there with the assessment now.
You can see it now?
Yep, we can.
Oh, maybe it's just loading a little bit slower.
It might be. I will just chime in if we don't see something so that you know about it. Okay, thank you.
Thank you. Okay, so the pediatric Glasgow Coma Scale. This takes into effect that infants really you can't do a normal Glasgow Coma Scale on them. So this helps you assess that pediatric Glasgow, their neurological status. And most importantly even is that motor response too. If you're having a hard time, making sure at least if you can get the motor response on the patient and make sure that's adequate, that's kind of been shown to be one of the best component for that Glasgow Coma Scale. So Glasgow Coma Scale, it is important to get. The next thing is the pupils. And I'm just going to assume this is going to pop up here in a second, but this is just a picture of the pupils showing the equal pupils that react equally. Pupils that react slowly. Dilated pupil can mean that it's a compressed cranial nerve. Bilateral dilated fixed pupils. Okay, this is an ominous sign. And then your pinpoint pupils can indicate pons damage or of course drugs. And don't forget that kids get into medications. So if you do have a child that has those pinpoint pupils and you're thinking head injury, it also could be that they've gotten into somebody's medications. It happens a lot. The kids get into, they usually will visit grandma or grandpa. They have their medications out. They're not used to having everything put away. The elderly, they make those easy removal caps for patients now, which is great if you're in a house without any children. But when the grandkids come over, the kids are smart. They open those up, they get into the medications. And so we do see that a lot. And then the third thing is the blood glucose level, making sure that we're getting a point of care blood glucose on your patient. Exposing an environment is important for E. Okay. And so this is removing the clothes to look for additional injuries as needed. And just because you're not called for a trauma doesn't mean that you shouldn't be looking at your patients. Okay. Just provide privacy as necessary and make sure that we're keeping the patient warm. Make sure you have blankets in your truck and to keep the patients warm if you are taking all their clothes off, keep them warm. And I bring this one up and you can see here on the left that this is a seatbelt injury. The one on the back is something if you didn't assess that patient, then you wouldn't have seen this bruising on this patient's back if this patient was brought in for, you know, a respiratory problem or some other problem. And then the one over there on the right is what we call a handlebar sign. So very important, you're getting called for trauma, we know, strip those people down, right? You need to look for those injuries. But sometimes in the pediatric world, we can find things that maybe we weren't called for, but we see it anyway if we can investigate under the guise of looking, you know, or assessing our patient. So a lot of times people will lie, okay, I know, shocker, right? So we will get called for a child that is maybe having trouble eating or that they passed out. Okay, so I've gotten, you know, we had a case where the kid passed out, okay, is what we were called for. And then when the crew got there, they worked this patient up. She was tachycardic. She, you know, she was awake, but she was complaining of abdominal pain, told that, oh, yep, she just passed out. She was a young child and they did everything they should have, ran a 12 lead on her, and her heart rate was in the 160s, you know, what was causing her abdominal pain, her heart rate to be high, get her to the hospital. Sure enough, same thing. The hospital is working her up for some sort of medical injury or medical illness. They get her into her gown, and as they get her into the gown, they notice that she has a bunch of abdominal bruising. And so instead of it being a medical issue, it really was the fact that she had been abused and she had a traumatic injury and the bruising was there. It just wasn't looked at. And so there are a lot of hospitals as well that have now started gowning every child. And it's a way of making sure that they get an eye on all those kids to look for those, you know, even just bruising, to look for anything that could be a sign of abuse. So just keep that in mind. Same thing, get a lot of calls, kids not acting right, they're not eating right, and it could be a head injury. So always have that high suspicion. As far as keeping them warm, remember they have a large body to surface area. So they do lose heat a lot faster than the adult patients. Their ability to regulate temperature is less than that of adults. They have less body fat. And the problem is that hypothermia can actually increase oxygen consumption. So if the kid is cold and they're already having trouble breathing, it's going to make it worse for them because their body is going to be working harder to stay warm and increasing their oxygen consumption. And it can also cause coagulopathy in patients and trauma patients. So if you have a patient, whether it's an adult or a pediatric patient, and they're bleeding, but they're cold, it's going to be harder for their blood to clot and they're going to continue to bleed. So keeping a patient warm sounds simple, but it really does have a lot of benefit to it, to helping the patient. They also have thinner skin, so they're at risk for increased dehydration, and their severity of their burns because of this, because of their thin skin, their burns that may not be as significant in an adult patient will be a higher degree. So just making sure you keep the back of the ambulance warm for your patient, regardless of how hot you might be, the ambulance should be warm for your patient as well. Moving on to F, making sure you have a full set of vital signs and communicating with the family. So making sure that you have the correct size of the equipment. And do you have the size that you need, the blood pressure cuffs that you need? Can you take a pulse ox in a pediatric patient? Right? Sometimes the little clipper ones don't quite work on a little tiny 3-month-old, right? They're too big. Blood pressures can be done on children even less than 3. Something that I even used to teach all the time. And, don't worry about a blood pressure if they're less than 3 years old. Sometimes those are easier to do than the older kids. Okay. You can get blood pressures on kids less than 3 if you have the proper equipment. If they're young enough, you can do it on their leg, do it on their lower leg. That's the best, that's how we do it in the hospital. And then unless hindering care, the caregiver should be allowed to stay with the patient. And that's going to help keep that patient calm. Now, if that's not the case, then you may have to separate, or if the caregiver is causing more problems, then you may have to separate. But other than that, they really should be allowed to stay with that patient, properly secured, etc. But they should be able to stay with the patient. It will help you in the long run taking care of your kid. And so it's important to know what the blood pressure we're looking for. What is the minimum blood pressure for a child? Okay, what constitutes hypotension in a child? And what we consider the minimal acceptable blood pressure in most kids is going to be 70 plus 2 times their age. So if you have a 4-year-old, it would be 2 times their age. So 8 plus 70, so 78. They would need to have a systolic blood pressure of 78. You can do the pulse on their hands, their toes, the bottom of their foot, their pulse ox, But you also need to make sure you're getting a good set of respirations, and you may have to count for a whole minute. Okay, especially younger children don't always have the most regular respirations. So it may take a full minute of counting to get an adequate respiration count. So this again is just showing the hypotension in kids, just a chart here. So term neonates, so 0 to 28 days old, hypotension is considered under 60. Infants 1 to 12 months under 70. Children 1 to 10 years is the equation I just gave you of 70 plus 2 times the age in years. And children over 10 years, they fall into the adult world of less than 90 is considered hypotension. So very important to keep this in mind. When I brought up the full site of vitals for F, I mentioned families. And so this patient and family-centered care is a concept that's in the hospital world, not necessarily as much in the EMS world, but I think it's worth mentioning. It does lead to better patient outcomes. And the core concepts of PFCC is showing dignity and respect for both the patient and the caregivers, doing information sharing, and making sure you're keeping those parents informed in what you're doing. Yes, I realize it's a high stress situation. Yes, I realize you're busy. Yes, you don't have as many people as maybe the ED does to take care of the patient. Okay, but keeping them informed in what's going on is going to help both the parents and you, because they're going to be more calm and willing to help you if you are interacting with them as much as you can. Participating in the care of the patient. Okay, they're feeling helpless. They're standing there watching their child that's sick, and you are working on them, and they might need to do something. It may be as simple as, hey, mom, can you hold their hand? Can you, something that will allow them to participate and feel like they are helping out with the care of the patient, because in reality, they really are. They are helping. And collaborating with them, making them feel like they're part of the team. Takes some work. It's not something that you can just, start doing overnight. You have to get used to it. You have to feel comfortable doing as well, because you're already stressed because it's a kid, but you do have those parents there or the other caregivers there as well. So G stands for Get Resuscitation Adjuncts. So this would be getting our monitor, making sure our monitor's on our patient, and making sure that we're monitoring the heart rate. We're trending our blood pressure. Always try and get a manual blood pressure on your child if you can. Sometimes, some of the crews may not have the different size blood pressure cuffs for the pediatric patients. I understand that. They just have the monitors now. But if you do, try and get a manual blood pressure and use your monitor for trending purposes. The pulse ox and capnography, if you have it, the waveform capnography, the patient doesn't have to be intubated to have capnography. You may be lucky to have the nasal cannula capnography as for your respiratory patients. Pain management, Okay, making sure that you're doing not only pharmacological pain management, but also non-pharmacological pain management. And trying to reason with a young child doesn't always work. Sometimes you may have to use distraction techniques. After that, we can move on to the history. And I get it, in the real world, somebody else might have been getting this history. You may be getting this history while you're doing your head to toe or your, initial assessment. But we're always taught these in this alphabetical order. So history, symptoms, what kind of symptoms do our patients have? Signs and symptoms. Weight, so important. What is the weight of the patient if they know it? If they, they may have been at the doctor last week and gotten a weight. If not, use your length-based resuscitation tape to get a good estimation of the child's weight. Medications that they may be taking, vaccination status of the patient. Are they up to date on their vaccinations? Not a time for a lecture, not a time for political conversations. Simple, are they up to date on your vaccinations? If they say no, okay, move on. Allergies, are they allergic to any medications? Any past medical history? Okay, and last oral intake and last output. And then we can move on to the head to toe. And I'm not going to go through, checking for decap BTLS or any of that on here, but obviously do the head, the neck, the chest, the abdomen, pelvis, genitalia, extremities as necessary. And once again, I can't stress enough that if you are there taking care of a medical problem, if you can have a reason to take a peek at these kids, take a peek at them, look for any type of bruising that shouldn't be there, any other signs of injury. And then I inspect the posterior surface as necessary. And then things to keep reevaluating. Our vital signs, right? We like to trend our vital signs. Any of the interventions that we do, we need to reassess those, looking at our injuries, making sure we haven't missed any injuries. They still do this in the hospital. They do a tertiary review where they go in, within 24 hours and go back and do a head to toe on that patient again to make sure they haven't missed anything, because sometimes the big injuries overshadow those smaller injuries. Reviewing that primary survey, how's the patient's airway, how's their breathing, how's their circulation. You can't just do it once and assume it's going to be fine the whole time. And then their pain, right? And I get some people on this call will probably on this webinar may have 3-4 minute transport times. There's only so much you can do. Perfectly acceptable. But there's also people on this call that may have a 20, 30, 40 minute transport time. And so every EMS agency, every EMS call is going to be different. And so you obviously adjust this to what your situation is. And so what I did is I just threw in some of the common pediatric emergencies that you may run on. Obviously, for each of these, I could spend at least an hour on every single one of these. So I just kind of grabbed a few things from each one to kind of round out this lecture. So the first one, respiratory illness. This is one of the most common calls for EMS for pediatric patients. And right now it is crazy. Okay, so in Michigan, there are very few pediatric beds available right now. These kids are coming in left and right with respiratory illness. It is COVID, it is RSV, it is asthma, it is influenza. And unfortunately, a lot of them are coming in with more than one. Okay, so they may have asthma, but they're coming in with RSV. They may have RSV, but they also have influenza. They may have influenza, but they may have COVID. And then we're seeing a lot of sicker kids than we normally do. This year so far has been really bad. So you will be running on these kids. Right? And respiratory failure is the most common route to cardiopulmonary arrest in kids. This is why airway and breathing is so important. We've got to maintain that airway, recognize that our kid doesn't have a good airway, make sure we're ensuring oxygenation, because most kids have nice, healthy hearts, right? Those hearts are lovely. They're brand new. They're great. They're barely used, right? Because they're only 6 years old. Okay. It's not like a 7-year-old that's, it's an older heart. Their hearts are good, right? It is the respiratory component that's going to cause them to go into cardiac arrest. So we have to be able to recognize the signs of respiratory distress before it progresses. So suctioning and oxygenation is huge for these kids. So we classify respiratory illness into respiratory distress, respiratory failure, respiratory arrest. So respiratory distress, the kid has increased rate, increased effort. And then when they get to respiratory failure, they have showing signs of inadequate oxygenation and ventilation, and can then progress to respiratory arrest. So when they're in distress, you can see tachypnea, the nasal flaring, the accessory muscle use, and retractions. Okay, so this kid you can see is a little bit of retracting, right? Just kidding, a lot of retracting.
Lisa, can you show the photo? I don't know how you did it last time, but it's not,
I
there
don't.
it is.
Okay,
Okay.
so I'm not doing anything. It's just magically appearing.
Okay, thank you.
No, that's fine. That's fine. So you can see there, I'll just have to like wait even longer now for that photo to show up. But anyway, so this kid is definitely retracting, right? And what's sad is that someone took this picture. I'm hoping this is a home picture before they put oxygen on, and that they're not just doing this for pictures. But anyway, so it's an internet picture, not something that we did. Although I do see leads there. So someone did take this picture before they corrected this kid. All right, so failure usually is a result of fatigue. Like I was talking about, these kids will tire out. Okay, so you'll see alterations in muscle tone, mental status, their work of breathing, their color of their skin, or perfusion, or maybe they were like breathing 48 times a minute or 60 times a minute, and you haven't done anything, but you notice that, oh, wait, now they're at 24. Oh, they're getting better all by themselves. No, they're getting ready to crash, and they're going to go into respiratory arrest. And the respiratory arrest, remember again, that's going to be one of those things that makes them go into cardiopulmonary arrest. So things we want to know for our kids that we run on that are in respiratory, have respiratory illnesses. When did it start? What was the time of onset? Was it rapid? Was it gradual? What was the child doing when it started? What was their gestational age at birth? This means how many weeks were they born? Were they 32 weeks? Were they full term at 38 weeks or 40 weeks? Were they born at 24 weeks? Because their lungs may not be as developed, or their lungs may be damaged. They may be damaged from the amount of oxygen and that they had to have if they were preemie babies. So this makes a difference. A lot of our RSV babies that come in and have significant complications from RSV are usually preemie babies that were in the NICU. Okay. Have they ever had previous episodes of respiratory distress? Any previous NICU or PICU admissions? Okay. Have they been intubated before? Medications that they may be taking. So interventions ensure that they have an open airway, the suction, and down there on the bottom of the screen, that'll eventually show up if it's not there yet, is what we call a neosucker. Okay, and so this is a flexible, I describe it to my nursing students and to paramedic students as a flexible yank collar, because we all know what yank collars are, right? We always learn that in our EMS classes. But this is a lot smaller. It's probably 3 inches, 4 inches long, but it's flexible. And this is like the best thing in the world to suction babies. This is what we use in the hospital instead of bulb syringes. Okay? Bulb syringes work. They're great. You have them. They should be in your truck. But this little neosucker is also a wonderful tool to have. Works just like a yank collar. You can see the port there sticking up that you cover with your thumb. You can suction those kids out, because a lot of these kids, you know, especially the RSV kids, there's not a lot you can do for them except for maintaining their oxygen and suctioning them. It's the amount of congestion that they have. If you have the capability to give humidified oxygen, please give that to them. Bronchodilators, epinephrine, especially for your croup kids, and possible steroids. All depends. You know, we've got what, 5-6 states here on here. Everybody's protocols are different. I realize that. So I didn't want to put any, you know, actual guidelines down, because the level of EMS, the area is all going to be different. And I recognize that. The next one I put on there is fever. Okay. So fever itself does not need to be treated. So the goal of a kid, if you're getting called for a kid that has a fever, is to provide comfort and identify and treat the underlying cause of that fever. So to consider someone to have a fever, it has to be the body temperature greater than 100.4 or 38 degrees Celsius in a child that is appropriately dressed and has been at rest for 30 minutes. Okay, so not someone that's been wrapped up in 15 blankets and running around, whatever. Okay, that's what we consider a fever. And so when we talk about fevers, this is what we're in the world of EMS that we're actually getting called for, right? Is the febrile seizures. So the simple febrile fever, and I'm talking about a seizure here, tonic-clonic movements that last less than 10 to 15 minutes, but they don't reoccur within 24 hours. And the majority are going to be simple febrile seizures versus the complex febrile seizures, where these can be focal, they last longer than 15 minutes, or they recur within 24 hours. So simples are usually what you get in a kid that's otherwise healthy, that don't have any other evidence of a CNS infection. And about a third of these kids usually will have a recurrence of a febrile seizure within 1 or 2 years. And then, although they don't know why, they haven't figured out why, but those kids that are at higher risk are those that have a fever greater than 39 degrees. They have a first-degree family member that has a history of febrile seizures, and that they also attend daycare, or that they attend daycare. So they've recognized these as things that put them at higher risk, but they haven't identified the exact reason yet. So when you do run on these febrile seizures, though, it's important that we still transport them. Right? We don't know for sure if that's the only thing that's going on. Infants less than 3 months old are at a high risk for bacterial illness. Why? Because they don't have the immune systems. And as soon as then the mom's immune system that's been protecting them is starting to wear off. So any kid under the age of 3 months, they're really going to be worked up. And we have had a recent case of meningitis. Luckily, it wasn't bacterial, but it still happens. There's no evidence, and I think this is something to reassure the parents, there's no evidence that a simple febrile seizure causes brain damage. But it can cause tachycardia, tachypnea, and possibly hypoglycemia and or dehydration. And then antipyretics don't cure, they only alleviate temporarily. Another common EMS call are burns. About 20% of all burn victims are children. It is the third most common cause of unintentional injury or death in children between the ages of 5 and 9 years old. In toddler age group, scald burns are the leading cause of burns. And then more than 50% of children younger than 9 years old in structure fires will have some degree of smoke inhalation injury. And if you go back to that third line about the scald burns, for us in our area and pretty much everywhere, the scald burns are, I know when I was in EMS, I was always thinking of burns being from like house fires that my patients were going to be burned. When you talk about burns and you go through that section, it's going to be a kid burned in a fire playing with matches. No, it's the kids that are around the hot water. A lot of times it's for soup, right? They're making noodles, and their older sibling is usually getting the soup or the hot water out of the microwave or off the stove. The toddler will run into them and they get burned, or they're pulling it out and they trip, or they accidentally spill the water. And so we get a lot of kids that have the burns down the front of them. Very common. But it's also important to remember that burns, up to 20% of them are due to child abuse. The burns account for more than 50,000 emergency room visits each year. Scald burns are the most common, followed by contact burns. And interestingly is that abuse burns have a greater mortality rate than accidental burns. So scald burns, as I mentioned, this is actually a type of thermal burn. It's the most common burn in the pediatric population. As I mentioned, a result of the child pulling the hot water onto themselves. And a lot of times the parents don't recognize how severe it is until blisters actually begin to form. Okay, so there might be a little bit of a delay in presentation until they start to see that, oh my goodness, even though it was just water and it's not that thermal burn that most of us think that's what the burn's going to be from, or a kid getting burned, that they bring that patient in. So this is a patient, this was one of our patients.
Image is not showing up just yet, Lisa.
Okay.
Yep.
Is it there now?
No, I'll just stay on and let you know when it popped up. We're good.
Okay. All right. You know what? I'm kind of I'm moving my mouse around on it, so I don't know if that's actually doing it. But anyway, this is a child, same thing, toddler, pulled that, was bumped with the water. I can't remember specifically. I haven't looked at it in a while, but she either pulled the water onto herself or it was spilled onto her. But you can see that pattern of where it's going right down, down the front of her, where it's spilled on the front of her. And a lot of them are just trying to be like their older sibling and make the soup and they think they're helping, and then they spill this boiling water onto them. So if you have children, don't let them deal with the ramen noodles. I know my kids had to be older before I'd let them. So an article in the Annals of Emergency Medicine showed that the administration of cool running water decreased the burn severity, hospital admission, or interventions. So cool water, right? It recommended that adequate first aid must be prioritized by out-of-hospital and emergency medical services. So adequate first aid was 20 minutes of cool water run within 3 hours of the injury. So if you're running on these kids, they've just been burned, you may have to spend that. It might be prudent to stand there and do this 20 minutes of water on these kids, right? That was what they found in this article was the best thing for these kids was the cool water. Okay? And I know that we have learned not to put anything on the patient, but we still get people that bring stuff in. I'm running out of time, so I won't discuss that more, but don't put anything else on the burn. Head injuries, traumatic brain injuries, a leading cause of death and morbidity in children is the highest. It peaks, I think you can kind of imagine, in children less than 4 years, and then between the ages of 10 to 17 years. 62,000 are admitted each year for TBIs, less than 1% though need neurosurgical intervention. And child abuse is a common cause of traumatic brain injuries in infants less than a year. So management of head injuries, ABCs, monitor with pulse ox, monitor the end-tidal CO2 with capnography, minimize stimulation, and be prepared for seizures. Thoracic trauma. The big thing to remember with thoracic trauma, it is uncommon in kids, but what happens is that they have more cartilaginous rib fractures. So if you do have rib fractures, you can assume that it was a very high pressure, high mechanism of injury that caused that rib fracture. But what usually will happen is that energy, that traumatic energy will be transmitted to the lungs. And so pulmonary contusion is the most common serious chest injury you'll see in kids. And those are those things that you will maybe not even recognize in the field, right? It's one of those things that they're in an accident. The mechanism of injury may be there. It might not be absolutely recognizable, but they seem fine. They come in, they seem okay. Pulmonary contusions, I don't know about you, but I'm clumsy. I run into things all the time. I get a bruise on my leg or I hit something. I don't really pay attention. I'm like, yep, whatever, I did it again. But then the next day I have a bruise, right? It had time to blossom. It had time to develop. The same thing happens with the pulmonary contusions, right? They blossom is what we say, usually for up to about 72 hours after the injury. So you may have a child that you think is just fine, and then you find out they were admitted to the PICU for trouble breathing, and you're like, what happened? It was probably a pulmonary contusion. Abdominal trauma, 10 to 15% of the injuries. It's one of the most common unrecognized cause of trauma-related deaths. 90% is blunt abdominal trauma, 10% is penetrating. And blunt abdominal trauma is the third most common cause of pediatric trauma-related deaths. And so this is that picture again, or it should be popping up, of the handlebar injury. So seatbelt sign, handlebar injury. For our hospital, this is considered enough to trigger a trauma activation, okay? Because of the research that has shown the high incidence of injury when you see a seatbelt sign or a handlebar sign. This is just talking about the fact that they have larger abdominal organs. The most frequently injured organs are spleen and liver. Usually we see a lot of spleen injuries. They're more anterior, the liver and the spleen. Okay. Physical child abuse. I've touched on this a little bit during this lecture. Once again, I could spend hours talking about this subject, but I have like 5 minutes. So anyway, just remember that a lot of these cases, 70% were children under the age of 3. It's important to recognize sentinel injuries. Sentinel injuries are those injuries that don't seem like they're that bad. They're bruising. It's just minor bruising, but they're in areas that you wouldn't expect, maybe like a 4-month-old to have a bruise on their thoracic cavity or on their face. All right. That's not normal. So yes, it may not seem like a big deal. It may not warrant EMS transport, but by having that child checked out, you may be saving their life, because usually that's how it starts. And then the abuse gets more intense. And there you can see there's an increased risk of mortality with that recurrent physical child abuse. Documentation, everyone's favorite thing in the world. It really is important. We use for patient care. We also take EMS data and put that into our trauma registry. And actually, the trauma data is now that really super long number that all of your run forms have now are being synced up with the trauma patients, and it's being dumped into the trauma registry, which makes it really nice to be able to have your data mixed with the hospital data now. And it really does provide the best information of what actually happened, as I mentioned earlier. When we look at it, my chief of surgery, he's always looking at the EMS run reports. We read it. Hey, you may think no one's looking at it, but we do. We read it. It really is important. Make sure you're stating the facts and leave emotions out of it. We want to make sure we have the medical history, the medications, allergies of these kids, the treatments given prior to EMS, anything you've done. And one of the big things is how much fluid you've given the patient. So when I'm doing classes for nurses or physicians, it's important, I tell them, you've got to listen to EMS. You've got to find out how much fluid they've given to the patient. That is a big deal. That determines whether or not they're going to get blood sooner or later, or if it's a burn patient, if they need to readjust their calculation for their burns. Okay, so it really does make a difference. It really is important. Put down how much fluid that patient has gotten. I don't care if it's a scene patient or a transfer patient. We need to know how much fluid they've given. And it's my goal to make sure that they're listening to you as well. Okay, I worked in EMS. I worked on the road. I know what it's like to walk into an ER and try and give report. I know what that's like. Okay, I get it. And so I try to educate both sides. Intrusion, that's a big thing. And I just was telling my nursing students the other day about this intrusion. They weren't even aware how intrusion was more important than the damage to the vehicle, right? Everyone freaks out about what the vehicle looks like, but those of us in EMS know it's really the intrusion, how far in that car went, into the passenger compartment, that makes more, is relevant for the patient versus the actual damage to the vehicle. Where they were in the vehicle. You'd be amazed how many run reports I read that don't have that in there, or whether or not an airbag or seatbelt was used, or helmets. I get a lot of calls. They don't document whether the patient had a helmet on or not. And then car seat. What kind of car seat were they in? Unfortunately, we get a lot that they're in the car seat, but the car seat isn't strapped down. And if you look at the new 2021 field triage guidelines, that say where EMS should take patients to a trauma center or the highest level of trauma center. This just came out, in the last year. If that car seat, and they could be in a car seat, but if it wasn't properly restrained, because some people will stick that car seat in and forget to buckle it, it happens. That's a red flag for a possible trauma. They have to be properly secured in that car seat and properly secured in the car. So if you haven't had a chance to look at those guidelines, or the new field triage guidelines, it is worth looking for EMS. I just went over it myself, and it was really interesting to see the difference. Talked about helmet, how high they fell, anything over 10 feet for children. Okay, it used to be 2 to 3 times the height. Same thing I was talking about, the new guidelines, they're switching it to 10 feet, right? For all around, whether it's an adult, a kid, etc. 10 feet. None of this different age stuff. How fast the vehicles were going, whether or not extrication was needed. Extrication is also in the field triage changes. It's no longer 20 minutes. It's whether or not the patient needed to be extricated. Doesn't matter if it was 20 minutes or not. GCS, it's now not 13 or less. It's now a motor score of less than 6. And that's why I brought that up back in when we did the GCS section. Vital signs, and I talked about the amount of fluid. So cheat sheet. Be prepared, all right? Be a part of the pediatric pre-hospital pediatric readiness project. So all of the EMSC people on here, that is their whole world, is the pediatric readiness projects for both the adult and pre-hospital. There is a pre-hospital one. Most of you, if you're pediatric champions or PECs, you know about this. If you don't, get involved. This gives your group a really good checklist of what equipment you should have on your trucks. Stop the bleeding, all of the bleeding, every red blood cell counts. Ensure adequate airway, maximize oxygenation, limit your crystalloids if possible. And that just kind of goes, we want to make sure we're getting blood into them, and make sure you're keeping the patient warm. This is the website for the pediatric, the pre-hospital pediatric readiness website, but I can't stress the amount of resources that are on this website, on the EMSC website, that you can use for EMS and the education that's on there. So if you're not aware of it, please, I implore you to get involved in it. Take a look at it. There's a lot of good stuff on there. All right, my references. This is my information. If you do have any questions, please feel free to reach out to me. Like I said, I worked in EMS a long time, but I'm in the hospital. I went to the dark side and work in the hospital now for the last 5-6 years. So a little bit longer than that. So any questions? I haven't been able to see the chat box.
Thank you so much, Lisa. Fantastic presentation. I'm going to field several questions to you while we have a little time. So our first one kind of goes back to suction. There was a question if you could clarify the type of suction that you were discussing that was ideal for pediatric patients.
Oh, it's the Neo sucker. That was it. And so the Neo sucker is, like I said, it's a little Yankauer like device. It's flexible. I think the Neo sucker is, you can probably put it in there, and it might, I don't think it's a brand name. I think there's another name for it. I just don't want to get in trouble for, I'm not recommending anything. I don't want to get in trouble for that. It's just what we call it in the NICU, like when I worked in the NICU for about 7 years. So it's really good. You can, even if you use a couple drops of saline and use that in their nose to get the boogers out, especially if they've been on oxygen for a while. But suctioning their nose, suctioning their mouths. And I'm glad someone asked, because I also forgot to mention that you really should make sure you decrease that oxygen or the suction down to like 80 to 100. So you're not like sucking their whole bodies out of their nose, but or mouth. So you would have to decrease the amount of suction that you normally would have for an adult patient.
Thank you, Lisa. We got a couple more here. And yes, we will be putting the EIIC link in the chat. And we're also going to gather all the PowerPoint slides from our speakers and compile them and send them to you all via email after the recording. So just wanted to address those two things. Some other good questions came up regarding burns. There's kind of a two-part here. So it's not a good idea to wrap burns of children. And can you clarify more about cold water on burns?
Okay, so the cold water is just a cold tap, you can use your sterile water if you have it, or even it's something that maybe dispatchers should be informing the 911 caller to do too, is to start running even tap water on the burns. But that was just a research study that showed that 20 minutes really decreased the amount of the further need of debridement in the OR, et cetera, in the severity of the burn, better than anything else, better than putting anything else on that burn. Cool water really did it. And it's and that's the initial treatment. We know that we don't want to use cool wet dressings on anything that's greater than 10%, because then we're making them hypothermic. So yeah, so once you wash or rinse those burns for the 20 minutes, you then can put a clean sterile dressing on them. But when I meant not put anything on it, I meant we get people that put mayonnaise, butter, Vaseline, mustard, stuff like that. And not that I would expect EMS to do that, but we do see other, the bystanders or the parents, caregivers doing it because that's what they've been told. And unfortunately, then it just needs to be scrubbed off the patient when they get to the hospital.
Absolutely. Yeah. Some comments about people seeing things like ice and very cold things placed, which can be detrimental. So just keeping that in mind.
Yep.
And then the recommendation being a clean, dry, loose dressing, right, to prevent the hypothermia. Okay, awesome. 2 more quick questions. I've often heard kids don't really compensate that well. It's more like they compensate for a period of time and then they drop off suddenly, very unlike adults. Can you confirm, deny, and maybe explain a little bit about that?
Confirm. And it's the same thing. They have those really good hearts. You're absolutely correct. Whoever asked that question, absolutely correct. They compensate, they go and go and go. They have those great hearts, but then they just get so tired, they just drop. And they're just, once they drop, once you get a kid into cardiopulmonary arrest, into full arrest, it is really difficult to get them back without there being long-term complications with the kid. So yeah, that's why it's really important to notify. And I stress this with the adult world too. You know, if you see that higher heart rate or you see that increased respirations, you don't have to have somebody that's got a low blood pressure, you know, or a major gushing bleeding to know that they're really sick. We really want to stop it then before it gets too bad. But absolutely correct. They do compensate for a long time. And we don't know any, the EMS world or even the hospital world, we don't know how long they've been like that. The parent may have just noticed that kid when they got up in the morning. They could be compensating all night long in their bed, sleeping, waking up, and they've been going for a long time. So if that patient then crashes on you, you know, that's because they probably were compensating for a long time. The parents didn't recognize that the kid was compromised or compensating.
Last question that we have time for. Any recommendations for transportation regarding a febrile seizure when they have a history of these and Tylenol has been administered?
Yeah, it's like going back to like when I was on the run. Like, I think it's important if the parents are comfortable not transporting that patient. I mean, I think that's a call that needs to be made with the parents' comfort level, and maybe a phone call to the ED to talk to medical control. I think it's those ones that it's their first febrile seizure and we don't know for sure that's what's going on. So I think it's one of those case by case basis where I get it. If they have a history of febrile seizure, the patients, you know, the parents are comfortable and, you know, you feel comfortable that they're going to call the physician the next day, or they know to call back and the patient's alert and acting normal. You know, one, it has to be a comfortable situation for both you and the parents. But you know what, we work under medical control. Let them also be involved in that decision making. And, you know, I know Dr. Mishra, you were in the ER, so I'm hoping you would agree that, you know, make it a shared decision between you and your medical director.
Definitely.
Parents will just say no. I mean, and you can't force it.
Thank you very much, Lisa, for your time and also for all your fantastic questions. I don't see any new ones coming in right now. I'm actually going to be compiling questions that come in, so thank you for sending them. And like I said, we're going to gather the PowerPoints from our speakers and be able to share them with you. So I just want to say one more thank you, Lisa, so much for being here with us tonight. And if you have anything additional resource-wise that you would like to share with these students, send them to me in an email and I'll compile them with your PowerPoint and get them to them.
Okay, sounds